So, hello everybody. I'm glad to open this session on shaping the treatment of mitral regurgitation with the Intrepid transcatheter mitral valve replacement system at this Monday lunchtime, and we're already competing well against the lunch. It's my great pleasure to co-chair this session here with my good friend Thomas Modin from Bordeaux, France. My name is Rolf Stefan von Bardeleben from Mainz, Germany, and Montreal, Canada. And from the North American continent, we have the famous Michael Reardon from Houston, Texas with us, who is an experienced member of the steering committee and of the trial here with the Apollo. And he will report for the first time the 5-year durability data. We have Dan Blackman here from Leeds, UK, and we have, of course, Paolo Denti from Italy, who will join us in the discussion and will seize some further insights. So without further ado, I would... Michael, you want to start? Yeah, that's fine. I think I'm first, but I'll give you the option, of course, Michael. So
I thought the Americans don't come before the Canadians.
But the Canadians are 51st state, so you see that's earlier than the third. That's okay. So I'll give you a short introduction, though, and I'm happy that Michael will continue, and of course. We honor that the US have about tenfold the population, but we have more water than the US. So as we are in London, we have to speak about the water too. So I'll start with the Intrepid TMVR system. And it's my great pleasure that we've seen a lot of movements ahead this year, also compared to last year's London Valves, where we also spoke about the Intrepid TMVR system. And I'll just give you an overview of the timeline and on the design features of the valve. These are my conflicts. So transcatheter mitral valve replacement has now, after over 12 to 13 years, come of age and has the potential to be a very effective option for high-risk patients that are actually not eligible for neither surgical or transcatheter repair. We know that the mitral apparatus is complex, and it can also present a challenge for TMVR positioning and fixation. That is why there are not many devices out there, and you will see that we advance quite significantly with the Intrepid platform. The feasibility of this platform has been shown with the 35 French transfemoral system that was a transfer from the transapical system for the treatment of mitral regurgitation, and this has been previously reported. We now report on the first 100 patients with the new and smaller 29 French transfemoral system that is currently under investigation. So if you look at the first generation of the Intrepid TMVR overview, we have a double stand situation with a more rigid inner stand that confirms the round and circular shape for the valve leaflets themselves. And we have a conformable outer stand which anchors without a leaflet capture. It's a symmetrical design that eliminates the need for a precise rotational alignment. The circular inner houses a 27 millimeter tri-leaflet bovine pericardial valve that is open for future treatments, and currently we have the 42 and the 48 millimeter valves in clinical evaluation. The journey has been a significantly long journey, and I told you that we know TMVR for about 13 years. So this action is going on, and we will have Michael speaking about the early transapical system experience, which also gives us an overview of durability now. And this journey started 10 years ago with the transapical system. To be new, it was a recoverable system, which I think is a very important feature to the device. So you can step back and step in at a very late stage of about 90% deployment. And it's a single stage deployment. So we don't need an anchoring system. We have a single device that is implanted with 2020, the second generation, as a transfemoral system. The journey there started 5 years ago with a 35 French profile, single-stage deployment, and went on today with the second generation of a transfemoral system with now more than 100 implants with a 29 profile and also a single-stage deployment. This gives you a short situation of the valve system. We do a transaptal puncture, we pre-balloon the transaptal access, and we have then a wire-free implant of the device with a capsule that goes along to the mitral annulus, goes into the left ventricle beneath the two papillary muscles, is then positioned, first exposed atrial, put down into the annulus, and then fully deployed and delivered. So this single-stage deployment can be seen here. Until this moment, the valve is retrievable, which is very important. And here you see a release, which takes about 10 seconds if actually in the position. The valve is currently being deployed under rapid pacing with a high procedural success. So in the EFS of the 35 French system, we had a procedural success of about 94%, with a time from femoral incision to closure of 140 minutes. This is a little bit more than 2 hours, and a time for device delivery, catheter delivery, of 40 minutes, with the numbers actually going down significantly with experience and over time. So the deployment mechanisms, along with the approach and the navigation, are similar to the previous 35 French system with the new 29 system and other commercially available mitral repair devices. So the modifications to the 29 French system have been to increase the screen pass rate of the device, and this is mainly LVOT clearance along with the annular dimensions and differences in the oversizing of the device. To give you an impression, this is the comparison between the first generation device on the left upper and the second generation Intrepid device on the left lower. And what you can appreciate is that the shoulder of the device and the sealing area has been reduced by some millimeters in order to open the LVOT clearance for the device. At the same time, the valve moved up some millimeters into the atrial space, giving this additional clearance and reducing the impact in the left ventricle. So while the inner stent with 27 millimeters stayed the same, also the outer stent design has a difference, as you can see here, with a flatter shoulder beneath the landing zone. And again, there is no leaflet capture. The initial shift of the different system has significantly helped in actually enrolling patients. And you can nicely see that since 2025, so only this year, the number of enrollments in the trial has been significantly increasing. And we also have a much higher screen pass rate that we'll discuss about in the upcoming minutes. So the Intrepid TMVR is aiming so far at unsuitable patients for surgery or for TEER, which is basically the orange to red zone in the structural heart paper by Scott Lim. And these complex anatomies can all be treated. If we look into the patient group, we're seeing more and more Carpentier 3A and 3B patients, also with severe MAC. This is an experience that we see across the board in TMVR implants. We can treat extreme mitral valve complexity, cleft leaflets, short posterior leaflets, tethered leaflets, and also large coaptation gaps, which are no contraindication to this valve. I'll just give you one example because before we go into the durability data, this is a 71-year-old female with moderate severe MR. Etiology is a 3A pathology, which is quite common. So we have a systolic and a diastolic retraction in opening and closure. You can nicely see the distribution of the MAC. We see a good and preserved left ventricular function. There has been no previous mitral valve surgery, and there still is renal function. And you can nicely see that this valve anchors nicely into this valve anatomy with a dynamic motion of the stent frame and an excellent function of the device with low single-digit gradients across the device. What has been seen is a learning that we learned also in the tricuspid replacement field in the last 2 years, that we have an improved cardiac output by relieving AV valve regurgitation. And this is seen out to 2 years in the initial Intrepid TA TMVR studies. And I'll go shortly over this because this will be dealt with in detail by Michael Reardon, but it's an important situation. And the second important notion is that we eliminate mitral regurgitation, and we consistently over 2 years improved New York Heart Association class, which I think is highly important. To give you an overview of the numbers, we have now more than 650 TMVR implants with the Intrepid platform in the different generations. We have now almost 400 transfemoral, transseptal cases, and we have more than 100 implants of patients with MAC, which I see as a very, very important patient population that so far has a high risk for surgery and is undertreated and has an unmet clinical need in the population. So this is the last outlook. This was this Friday, just before taking the plane to London Valves. On Friday, we did the first German Intrepid 29 French implant with a very positive result, and the patient is about to discharge today, latest tomorrow. It's doing very well, no bleeding issue, perfect valve function, no situation on paravalvular leaks. So I thank you very much, and I would hand over now to our larger south of the border US partner to really give the numbers of the first durability in the 35 apical system. Michael, please.
Well, first of all, Stefan, I may need to move to Canada someday, and I don't want to be banned in Montreal, so do not tell them a Texan jumped up before the Canadians. I do not want to get in trouble. So I'm Michael Ridd. I'm a cardiac surgeon from Houston, Texas. I've been involved with this trial since the beginning, and I'm going to talk a little bit about the experience with the transapical Intrepid, which was really kind of our early pilot feasibility trial looking at the safety and efficacy of putting this in. But what we're going to focus on at the end is the performance and durability of this valve, because the early data showed us we could do this safe and with efficacy. The real question is, will these valves hold up in the very hostile mitral environment? These are my conflict of interest. As Stefan already told you, transcatheter mitral valve replacement has already shown itself to be a feasible alternative for patients with symptomatic, moderate to severe, or greater MR who are really not suitable for conventional surgery or TEER. The 5-year durability data and clinical outcomes have not been published, even though we've done the 2-year outcomes before this. We enrolled 95 patients in this prospective, multi-center, non-randomized global study at 21 sites in Australia, Europe, the US, and we now have follow-up through 5 years. Our primary endpoint of this early pilot study, which started in 2015, a decade ago, was the assessment of the nature, severity, and frequency of complications associated with the delivery and implantation of the transapical Intrepid system. And we're going to look at 5-year outcomes. The key inclusion criteria for this trial were moderately severe or greater MR, higher extreme risk by the local heart team, suitable anatomy for Intrepid TMVR, and no or minimal valve calcification. Key exclusion criteria were pulmonary hypertension, systolic of 70 above or two-thirds of systemic, prior mitral valve surgery or intervention, EF less than 20%, need for coronary revascularization, and renal insufficiency. There were 10 sites in the US, 8 sites in the EU, and 3 sites in Australia. This is our patient flow. We attempted implant in 95 patients, and we actually implanted 92. 2 of them had a malposition or embolization of the valve and were treated with surgery. 1 had massive bleeding from the apex, had to go on bypass, and had an attempt to fix this. So at 30-day follow-up, we have 95 patients, but 2 patients that had surgery and survived withdrew based on protocol. At 1 year, we now have 93 patients to look at. Between 1 year and 5 years, we lost 1 patient to follow-up, meaning that we have 97% of these patients with known vital status at 5 years, which for any trial is a very high rate of known vital status. If we look at the baseline, they're 74 years of age, 30% were over 80. Of real importance, almost 90% of these people come to us with functional class 3 or 4 symptoms. These patients are really sick. They have the comorbidities that you would expect. Almost 60% have been hospitalized for heart failure the prior year. Almost 50% have had prior heart surgery. And also very importantly, because when you look at these trials, you have to know what kind of MR, 80% secondary functional MR, 20% primary or degenerative MR. And again, EF 45%. All-cause mortality goes up very quickly in the first 6 months. No surprise. These are all patients that I would not operate on as a surgeon. These are all patients with a very high comorbid burden, and the morbidity of a transapical led to a high mortality in the first 6 months. It flattens out somewhat after that, but remains high, exactly what you expect. I've compared this against the 2- and 3-year mortality in the Tendyne studies. They are exactly the same. Heart failure hospitalization, half of them had already been hospitalized before, fairly high in the first 6 months. It levels off, but again, high. These are things that we'd expect, not really concerning in this early high-risk population. If we look at the all-cause mortality, it doubles between year 1 and year 5. Cardiovascular mortality goes from 26% to 51%, 19 new deaths. But if you look at these deaths, only 5 of these deaths were adjudicated by the events committee as having to do with the valve. 1 endocarditis, 2 fatal strokes, 1 subdural hematoma that happened at a fall after cardiac arrest, and 1 stroke that led to pneumonia. The patient eventually died of pneumonia, but it was adjudicated to the heart. So only 5 out of 19. If we look at myocardial infarction, it seems a little worse when you first look at it, 0 at 1 year, 10 at 5 years. But you look at these 10 patients, they all had a high coronary burden. Of these, 8 either had a prior MI, prior coronary bypass, or prior PCI, so not really surprising. There were 4 fatal bleeds. These were all early in the trial, none after 1 year. And after 1 year, there were 2 life-threatening bleeds. One was a subdural hematoma, and a patient had an INR of 9.5. And one was a patient that was having a peripheral vascular stenting, and they had a little misadventure in the arteries and ended up being a life-threatening bleed, but none related to the valve. Valve reintervention, there was only that 1 reintervention that happened very soon after the procedure where the valve was misplaced. They put a balloon expandable valve in it. That patient did well, and no reinterventions after the first 30-day period, and no hemolysis. If we look at endocarditis and thrombosis, we look at it as a linearized rate per 100 patient years, as we do in all rare events that have a fairly even occurrence over time. In endocarditis, 1.17 per 100 patient years. Clinically significant thrombosis with sequelae, 1.95, and without 0.939. This is very similar to what we see in surgical series. Mitral regurgitation, over 95% came to us with moderately severe to severe. There were a couple patients that were put in originally as moderate severe to severe that on echo core lab by the Mayo, they were felt to be a little less than that. But then you look at 5 years, and that 95% that was moderately severe to severe is now down to 81% none trace, and all the rest are mild, nothing beyond that. Paravalvular leak, nothing beyond none trace at 5 years. So this valve works, it gets rid of MR, it works really well, and it works well over time. Mean gradients in peak LVOT, they're low, they stay low. Again, this valve has excellent performance over 5 years. If we look at the unpaired echo, the ventricular dimensions don't change much. The ejection fraction falls as you would expect, but more importantly, the forward stroke volume, as Stefan has already told us, goes up because everything the heart ejects is now going forward. And also importantly, we all worry about this backwards failure of the right heart. We go from RV dysfunction of mild or greater of 67%, we go down 30% at 5 years to 44%, and the PA systolic pressure goes from 48 to 36. We see the right heart recovering from this, no increase in tricuspid regurgitation. If we look at paired echo data, we see the same thing, forward flow goes up, but now RV dysfunction actually falls even further from 76 to 47, 60% increase improvement in the RV function. PA systolic, 46 to 39. Again, we see the RA starting to recover, something that's really important because once your RA is gone, there's not much I can do for you. If we look at functional class, we start off with 90% functional class 3 and 4. We end up with almost 90% functional class 1 and 2. These patients do well and feel really well. And most importantly, this is the takeaway slide. Hemodynamic valve deterioration. Will these slides survive in the hostile mitral environment? If we look at the definition of moderate hemodynamic valve dysfunction as an increase of your mean gradient of 5 or more from your 30-day or discharge echo to current, or newer or increasing transvalvular gradient of moderate greater, 1.4%, only 1 patient. Severe, definition increase of 10 or more, or increase of your transvalvular to moderately severe or more, none. So the deterioration at 5 years in this very hostile environment remains very good. So really the takeaways from this pilot study, very early high-risk patients at 5 years, demonstrated that using the Intrepid transapical system, we had sustained mitral regurgitation reduction and valve performance. With the transapical Intrepid, we had no mitral regurgitation or PVL above mild, assessed by the core lab or the site at protocol specified or unspecified visits. With the Intrepid, we had moderate hemodynamic valve deterioration observed in 1 patient only, 1.4%, no severe dysfunction. We had 1 mitral valve reintervention that was, as I said, was several days after the procedure for a valve malposition that was treated with a balloon expandable valve, none thereafter. Thrombosis and endocarditis rates are consistent with what we see in surgical valves, no cases of hemolysis, and really improved functional status. As Stefan has already taken you through, we're moving forward to the future with the 29 French transfemoral system. Thank you very much.
Thank you. Thank you, Michael. I think we discussed the case together with Thomas Modin's presentation, who will lead us into the new 29 French platform so that we have a whole picture there to see how we did this transition and spectacular durability data. So I think it's been a good pause now to see what has happened with the latest generation of the device. Thomas.
Yeah, so thank you, Stefan. Yeah, so we're going to show you, give you an overview of what's happening today, especially in the Apollo EU trial. These are my conflicts, of course. So I'm not going to spend a lot of time here, just to remind those who were not in the room when Stefan was showing this, what is the Intrepid valve about? It's a dual stent design with an inner diameter of 27 millimeter. And this valve anchoring does not rely on leaflet captures. It needs an expansion at the level of the annulus itself, and it has some anchors that symmetrically anchors in the leaflet and into the annulus. So what is important here to show, is that the durability of this valve is matching our expectations and needs, and this was one of the biggest questions about replacing mitral valve in our patients. This question exists also for surgical patients, and we were very happy to had this tendency of durability increase or outcome, and this has been confirmed by the presentation of Michael. So I think there are very few reports on other repair treatment options with more than 5 years follow-up, so I think this compares favorably. So what is Apollo EU trial about? It's a team, it's a multidisciplinary team who's going to look at a clinical profile of patients, but who are not suitable for other mitral or surgical or repair transcatheter therapies. And this has been done on purpose, of course, because we wanted to clearly identify which patients can benefit of this therapy in comparison with the available transcatheter or surgical. So there's no competition in the design, but this is something we wanted to happen. So we had this primary cohort, and we had the role in subjects, and the primary endpoint was a 1 month and one month regurgitation data together with the all-cause mortality at 1 year. So these are some examples of patients that we are treating with Apollo EU trial, but also it's the same in US, and who are not considered to be suitable for repair and surgery. And this is what Stefan said, they are in the orange and red zones, where we know that the other options are not really good. So severe MAC, calcified leaflets, multiple regurgitation jets that could lead to stenosis if you use a tear, for example. Cleft leaflets presence. You can put a tear in a patient who has a prolapse, for example, but you can distort the valve, and because of this, you can increase or provoke a regurg. The tethered leaflets, a large coaptation gap, so everything that renders the tear reduction efficacy unlikely to be predictable. And of course, some other factors are related to imaging. I think imaging is also one of the subjects that we have to progress on. The inclusion criteria are, of course, moderate to severe symptomatic or moderate symptomatic mitral regurgitation, but combined with mitral stenosis in the presence of MAC. So the MAC profiles patients that we are including, in more than 100 patients now, as Stefan have been saying, could be interrupted. So it's what we call a band-like MAC for anchoring, but we don't rely on the presence of MAC to anchor solidly in the annulus itself. It could be also what we call partial, fragmented, and with a height considered to be moderate to severe. You see that? And there's no real obstacles. We have been treating patients with a protrusion into the lumen that we know that we cannot be treated with other therapies. With the commercial crossing, we treated patients with anterior leaflet location, also calcifications, circumferential extent, and irregularities, as I've been saying before. 3 examples of patients with MAC, and look, what's striking here is the volume score of MAC. 27 millimeter cube. It is something that is frightening. Even surgically, you don't want to touch with these patients, and I'm not sure that you can treat them with any other patients. But there are too many of them out there. We undersee them, they are under-referred, they are under-reported, but there are a huge number of patients out there like this because everybody thinks that we cannot treat them, and I think this therapy is a promise. So the way we look at the other big factor of non-eligibility, I would say, is the LVOT. Okay, so this group of steering committee members is looking for the neo-LVOT assessment. We will have a couple of minutes on that also. And we look at the end systole with using the cone method. So this is the cone method helps us shaping, I would say, or simulating the Intrepid in the presence in the annulus itself. And we want to be sure that we have a minimum neo-LVOT area at the end of the systole of more than 2 centimeters square. So if they may fail if we consider that the minimum neo-LVOT is below that number. So we don't continue the process of screening. They can be borderline, and then we ask to perform, or we look at the faces analysis, and they can be also green, and then the patient is sent to screening committee determination and validation. So this helped also accelerating the pathway and the process of examining patients that you are sending or you're reporting. We wanted to move forward with the screening methodology, and we have been made some improvements here. These are examples of the challenging anatomies that lead to high-risk LVOT obstruction. It can be related to different factors, mainly small LV, you can see it, small LV with hypertrophy, and small an angulation between the aortic and the mitral, which is, I would say, not favorable. So you can have a good left ventricle, but the angle is very narrowed, and because of this, you know that the valve is going to end touching or going below the aorta, and this is at high risk of LVOT obstruction. So what we looked is that we analyzed multiple factors that could lead, that we know that could lead to this LVOT obstruction, and we identified, thanks to that, what we call the top factors that we used to develop this new method of screening and to increase the number of eligible patients. And actually, the consistent number of patients have been implanted in the last months thanks to this modified LVOT scoring system that helped us improving the accuracy and accelerating the enrollments in the study. It's not only related to the 29 French, of course it was easier, but it's also because of this huge work that has been done with the team from Medtronic. So quickly, we have lived this transition from the 35 French to a new generation of the 29 French. The design of the valve is changed, so we didn't lose a lot of time. I mean, we've been working hardly since 2015 to make things better, and the team of engineers and the clinical team of Medtronic have made a huge progress with this, and then we are very thankful. And I think this is why also we have an acceleration. So you see that Apollo EU is very similar to Apollo US, which is enrolling faster, but I think now with the Germany Open, this is gonna be faster, and then I hope we can catch the American and Canadian pace. 38 Apollo EU trial sites, 18 US. All together with the 29. I'm very proud to say here that the first case was done in US by Portland team, Firas, our great friend, who came then to Bordeaux. We did the case with Stéphane. And I think this was important because this is a milestone, and this created a dynamic that we are super happy with. And I know Italy now is implanting, England is implanting, Spain is implanting, so we're very proud of it. And then we hope that we will be able very soon to terminate the study. So more than 100 implants with the 29 French system, and more than 45 centers with experience with this system. So what we're looking at is, again, a continuous improvement and iterations with this Intrepid next-gen system. We would like to have a larger valve because there are two important factors of non-eligibility. One is the size, and this is why we're waiting and expecting this large valve. And this is, I think, will lead to a clinical trial expansion. Thank you very much.
Please come over, have a seat. I think It's very interesting and fantastic data, and I was myself astonished to see that we've now treated 675 patients actually with the platform and with the iterations that have been shown. So Michael, you're deep in the project for the longest of time, and you've seen the advantage. What would be for the situation of stability, implant predictability, screen pass rate? What would be your major steps in this 1 decade experience of getting a TMVR platform actually to the patient, which is the most important thing? It's not only to be designed, but we have to get it in the patient, and it has to be robust in everyday use. So what would be your 3 major steps there in the 10 years?
The first step was going from transapical to transfemoral. When we started this, back when Tendyne came, I was asked to be the surgical PI for the trial. I turned him down because I didn't see a transeptal approach. And then I remember when we started, one of the surgeons we were working with said, well, you know, transapical is not that big a deal. Well, it is if it's your heart that gets a hole in it. So the first big step was going transfemoral. The next step was going to a 29 French with a redesigned valve. That's increased our pass rate for LVOT by about 20%. And when we get a bigger valve, that's going to add it up to one of the biggest problems with all the mitrals has been the screen failure rate. When M3 was presented, I was to discuss it. David Davison said we have a 35.5% anatomic failure rate, but I pointed out to him that the overall screen failure rate was 74.4%, which is what counts. That's something that needs to come down. And I think the next big step is that there's still engineering changes going on. We need to get this done, get this valve to market, and we're going to continue to work on the engineering, and the goal is to get the screen failure rate much less than 50%, and an ultimate goal is 20% or less. This valve works. It's easy to put in, and when you put it in right, it works literally every time. There are still learning curves that we're learning with this valve, but it's an easy valve to do. So I think there's been some real big steps.
Very important points, Michael. And Thomas, before we move to the cases in a minute, what about your learning experience and about the upscale of the enrollment in the trial that we've now seen with the April implant actually of the 29 French here in Europe? We know that already within the first half year we have achieved that 1/4 of the patients actually are now already been implanted in Europe, and we're seeing with the German sites and with other European centers that are now in the trial that we gain an upscale momentum. Could you just reflect a little bit on how the Apollo EU perspective was there that you showed in the transition?
I mean, in addition to what Michael has been saying, because again, we have been learning a lot from what is happening in US, and just we transported this experience to Europe. And I think the major advancement for me was moving from 35 to 29. I mean, remember that even if those patients are not suitable for TEER or other, the TEER is super safe. And reducing the Frenching added this feature.
Yeah.
So for the community in general, this was a very important milestone, and you could tell, I mean, that there was an acceleration. And the other major step for me that helped also is the new design of this modified LVOT risk calculation, because we wanted to decrease this number from 70 to below. So this is, I think, the most important steps when we talk about the other centers, at least in France, that help them and push them to join us in this journey.
So the acceleration of the rocket was first supported with heart surgeons, as you see on my left-hand side. There are only heart surgeons. I'm the only cardiologist here, joined by Dan. So we will now move into the cases. And I first ask in the sequence, again, a heart surgeon to show the review of the case number 1, and then we go from San Raffaele in Italy to the UK Leeds, and then I think we'll make a wrap-up discussion of the learning. So, Paolo, please.
It's just what I want to say. It's super rare to have more surgeons than cardiologists on the podium.
That's what I kindly wanted to introduce.
This is a major milestone.
So we're moving from 2/3 cardiac surgeons to, on the PI position, an equal 50-50 rate, so which I think is already a great movement, like with the cases. So Paolo, please present.
Thank you, Stefan. Thank you also for having this invitation on the behalf of our hospital that did the first Italian case. And then what I'm showing now is the second, and we have the third one that we are doing after the finish of London Valve. These are my conflict of interest. This is the typical high-risk surgical case that, unfortunately, or maybe for this case not, was not suitable for a good M-tier. 70 years old with a severe MR due to rheumatic disease, so type 3A, where there is, as Stefan said, there is a restriction of the leaflet in systole and diastole. Really symptomatic for dyspnea, so really sick patient that need a treatment. Good ejection fraction with a moderate MEC and a systolic pulmonary pressure of 51. No prior surgery, no prior other intervention, but for sure under good clinical management for medical therapy. The creatinine clearance was 33, so really at the edge for entering into the trial. But the quantification of MR, as you can see here, was severe. And again, also if you don't have experience with M-tier, you can clearly understand that this is not the right patient for M-tier. You can cause only a reduction in regurgitation, not an abolishment, and you can really increase the gradient. This was the measurement, so they are really important. Metroring team really help us in choosing the right size of the valve and also helping us how to deal with eventual implant problem that we can have, because they are measuring the valve with us, they are telling us what can be the interaction with papillary muscle, and we decide together if this is the right patient. So this is, I think, that is the most important slide of my case. Thomas said that when we have less than 200, we don't implant the patient. So this patient at the early systole has 152, and when the major ejection comes, so at 20%, we have 99. So a patient that I would say was not the best patient possible, to be really honest, to implant, at least for my experience with other technologies. But despite that, with this score, the patient has the green light, and so we decided to implant, and I can tell you from now that the patient did not any type of gradient at the flow tract. Again, we did the standard right femoral puncture with ProGlide. The puncture height was 4.1 centimeter, standard for mitral procedure. This is what they told us to do, to be really honest. We do the septostomy with a 12 millimeters balloon. Again, then we inserted after dilation of the vein, the first part of the device, confirming that we are 2 centimeters inside the left atrium. Again, at this stage, the procedure, I would say it's quite easy. Next step is the insertion of the delivery catheter in order to be at least 5 centimeters inside the left atrium. You can see here the nose that is going into the left atrium. At this stage, the first part of the catheter, as you can see in the second image, is retracted inside the right atrium. Again, another important feature of this valve that it is easy to implant. Everyone that has experience with M-tier knows how to do simple maneuver in order to elevate from the valve and to be coaxial. So the knobs are different, but they are doing the same job. They have only different names. For example, if you're looking here, we had to elevate from the valve because despite the puncture was right, we were too near the mitral valve. You see that this catheter is looking towards the mitral valve. And we know from M-tier that if we want to go away from the mitral valve, if we want to gain high, we have that to move this catheter posteriorly in order to gain high. In fact, if you look at here, the catheter is not looking towards the mitral anymore, but is looking in another direction. So every movement, it's, I would say, intuitive. Clearly, there are engineers that helped us because there is a learning curve, but everything, I would say, could be done, and they don't have to convince you. You already know that you are doing the right job. Then you open the brim and you position the brim 2 centimeters above the mitral valve. And again, similar to M-tier, you want to be coaxial in the intercommissural view and in the free chamber view. Here we are using MPR because we can be more accurate to position our valve. But again, it's really simple. You have to be coaxial in order that your valve touches the mitral valve in all 4 quadrants at the same time. Again, you do the deployment under rapid pacing. First, before the deployment, you do a mock, what is called a mock deployment, a false deployment. So you do rapid pacing, not like TAVI 220, but 180, 160, in order to stabilize the annulus. You try to go down with your valve, and if the valve is coaxial, is pointing in the right way, you elevate again the valve, and afterwards do the real implant. To do the mock implant is really helpful because you understand if your nose cone could interact with the papillary muscle or if the valve has not a perfect perpendicular trajectory. In this case, we have already done the mock deployment. We do under rapid pacing the standard deployment, and as you can see here, the valve was well opposed on all the 4 quadrants. This is the final positioning. No perivalvular leak, which is important. The mean gradient, which is 1 through the valve, and the peak gradient of the LVOT, which is 6 millimeter. I want you to remember that the LVOT was 99 millimeters. Okay, again, it is very important. They said to us this is a good implant because the first row of spikes, hooks, were at the base in all 4 quadrants, meaning that this was only our second implant. Professor Maisano was in charge of doing that, so he's an expert operator. But despite it was only our second implant, we had a good result, not only in terms of reduction in mitral regurgitation, but in terms of well position of the valve inside a rheumatic disease. Thank you very much.
Thank you. Thank you, Paolo. We'll discuss both cases together. And we now bring Dan Blackman, now from Leeds here in England, to the podium, and he will discuss about case number 2, and then we do the discussion together. Dan, please.
Stefan, thanks, and thanks for the opportunity to present this case. Yeah, as Stefan said, my name's Dan Blackman. I am one of the outnumbered interventional cardiologists, at least on the podium. And it's a pleasure to present our first case with the transeptal 29 French system in Leeds, having been involved in the transapical study that Michael mentioned earlier. These are my conflicts. So this was our case. So this was a 76-year-old man who was unsuitable for mitral edge-to-edge repair because of the anatomy, particularly restriction of the posterior mitral valve leaflet. So it was a Carpentier-Edwards type 3B, previous inferior myocardial infarction followed by coronary artery bypass grafting, which left him with this wall motion abnormality causing a short, restricted posterior leaflet and making our chance of achieving mild or less mitral regurgitation with edge-to-edge repair, in our view, unacceptable. And in every other regard, this patient looked a favorable case for TMVR. No other major comorbidities other than a degree of reduction in renal function, normal LV function, normal RV function, only mild TR and mild elevation in PA systolic pressure. If we look at the CT, I thought we had a small neo-LVOT until Paolo presented his case. And it is striking to think back that we used to think anything less than 200 and then TMVR is not going to be an option. But this patient also had a relatively small neo-LVOT, 1.23 centimeters squared. But after multi-phase assessment and LVOT scoring was felt to be acceptable in terms of risk of LVOT obstruction. In terms of the perimeter and the dimensions, it was again similar to Paolo's case, about 118 millimeter, which means we've got 25% perimeter oversizing with the larger of the 2 currently available devices, the 48 millimeter devices. And what we're looking for is between 10 and 30% oversizing by perimeter in the context of the Apollo EU trial. So this patient met the anatomical criteria both on perimeter, device size and neo-LVOT. So the procedure was conventional, a right femoral vein access, pre-closure with 2 prostyles, closure again just with 2 prostyles, a posterior puncture similar to MTIR, and we're achieving a puncture height above 4 centimeters. So we need that height in the left atrium in order to have room to deploy the atrial portion and advance onto the annulus. Again, septostomy with a 12 millimeter PowerFlex balloon, and that enables us then to bring the delivery sheath in, which is advanced about 2 centimeters into the left atrium over the wire we have in the pulmonary vein. Then removal of the dilator, maintaining carefully the position of the sheath at least 2 centimeters in the left atrium. And then once the dilator is out and we've de-aired the system, then we can introduce the Intrepid delivery system. So the Intrepid is flexed, advanced across the septum. Once we're comfortable with the position of the device and we're 5 centimeters in there, we can remove the sheath, bring the sheath back to the junction of the right atrium and IVC. And then we come on to the kind of key and the challenging part of the procedure. But I think, what our experience is that although in this case we spent some time getting that trajectory and that device orientation perfect, it was all done in an extremely controlled way. So we bring the inner catheter across the mitral valve, and as Paolo said, we're then into maneuvers that we're very familiar with from TIR experience of how to go posterior, how we go anterior, how we withdraw the system if we want to move medial, maintaining the same trajectory, advance the system if we want to go lateral, we flex or unflex in order to change the ML trajectory. And this is the key element of the procedure, as I say. We need to have a device that's sitting in exactly the same position relative to the medial and lateral and A and P elements of the commisure, so that when we bring the brim down onto the annulus, it's sitting in exactly the same height. We've got a device that's not tilted, so we can get perfect anchoring from the first row of cleats on the system that we've seen today. And again, like Paolo, I think the other thing we found that gave this procedure considerable control was our ability to have a trial run. So pacing on, in our case, the pacing to stabilize the annulus was 220, and then we bring the device with the brim exposed onto the annulus, then we come back again. Then we spend some time reviewing the echo loops, confirming that we think that device is perfectly orientated. In our case, we then made some further adjustments to just optimize the trajectory, ML and AP. Then we went for the deployment. But again, in fact, in our first deployment, we came down with the brim, and then we weren't completely happy with the orientation of the device. We came back up again, made some further final adjustments, and then with our second deployment, we were perfectly happy. Everything looked ideal. We deployed the valve. So here you can see the final result, and you can see, I think, hopefully, that if you look particularly in the kind of larger panel on the right there, that the device is sitting in all sides, ML, AP, the same distance just above the annulus. And that means, as Paolo was saying, that we've got engagement with the annulus with the first row of cleats, and that gives us optimal anchoring and minimizes any risk of migration or embolization. And the procedural result, the functional result, was similarly satisfying. No paravalvular leak, perhaps a tiny trace of transvalvular leak, and there was no need in this case to close the ASD. The patient's course after that was satisfactory. He did have a little bit of a femoral vein hematoma. That was managed purely by manual compression. He was discharged home after 3 days, and I've recently seen him 3 months post-procedure. Echo shows a perfectly functioning valve, and the patient is doing very well. So I think, this was our first case. We relied a lot on the incredible support we had from the Medtronic team. But comparing this to our experience 10 years ago, there's been an absolute transformation in the control and the predictability, and what felt to me the other key thing, if we're going to make this a viable competitor for edge-to-edge repair and hopefully a winner against edge-to-edge repair, the safety of the procedure felt fantastic. Thanks for your attention.
Dan, thank you very much. Join us here, and I think we should divide the residual time of about 6.5 minutes into 2 different types. One is to speak shortly about the 2 cases and the main learnings, and I think what we've seen is that we have a device that's retrievable until the very last step of the procedure. This is, we can deploy the valve in position, we can still have it near the capsule, we can retrieve it 90% deployed, functioning, and we could still retrieve the valve if needed. The second learning for me is that the results are exceptional even with the second implant of a center. I think this is something that Paolo mentioned, and this shows you that basic steps of this procedure are very similar to TIR procedures. So what we call towel twist to gain height or to remove the position to get an off-hugging position is basically the same what we're used from certain maneuvers like a plus or from a towel twist with a Pascal system, which is a repair system. And basically these catheters behave the same in the left atrial and mitral space. And my third point would be that this is the first single-step transapical mitral valve device that we have on the market. And we see that the deployment itself, once it's in a good position, is extremely fast. So we're moving from a functioning valve to a release valve in seconds. And those would be my 3 points. So Paolo, what would be your additional points from a steering, from an eligibility committee member situation, and from an implanter now in Europe? What is your major step forward, and how do you see perhaps the patient population cohort in Europe and in Italy?
So I have also experience with other devices, and what I can tell you is that what surprised me a lot about the Intrepid is the fact that there is the possibility to implant patient that has this narrow LVOT. In my experience, a number considered a good area for LVOT was 200, 250. I implanted a patient that has half of this. To be really honest, I trust in Medtronic team and also physicians that are working with them, but in the reality, it was something that I would a little bit scared about. But the patient is doing well. If you are able to implant such patient with such narrow LVOT, meaning that the population that can be treated with this device are broader than maybe other devices.
Perfect. Dan, you're coming from a public health system like in Canada, so we're all having certain restrictions on hospital beds and other situations. What would be your perspective from an implant to discharge of the patient perspective in the timing that we're now moving from transapical systems to transseptal systems? Does this make an impact on the hospital bed burden in the UK? It's a common problem in Canada too, so what would you see this procedure as it's evolving now to be positioned in your toolbox?
Yeah, it's a great question. I mean, I think obviously the move from transapical to transseptal is the big one, because I think, you know, we've touched on it, but if we're going to make this a clinically viable procedure, we need to have eligibility. We need to have ease of use in the procedure, and we need to have safety, because we know how safe MTIR is. And we've seen from other data that transeptal TMVR can be a very safe procedure. So for me, I think what we saw in this case is ease of use and predictability of the procedure. That was impressive. You know, it feels like we can tick that box. Safety of the procedure, you know, we need to see the data, but, you know, I think we have a procedure that has the potential to be safe. And then, as you say, you know, in terms of flow of the patient, it's going to be a completely different experience. These patients don't need to go to the intensive care unit. They're going to, in our case, a coronary care unit, a kind of level 2 facility for the first 24 hours, and then onto a regular ward until the patient's ready for discharge. The only thing that slowed our patient down was a hematoma, and I think, you know, that's something we maybe need to think, how can we get that balance of anticoagulation for safety and prevention of thrombosis and bleeding, and we, you know, and that's a question I think maybe for Michael on the longer term data, that these are high bleeding risk patients. So we're still trying to work out, I think, the right balance of how to anticoagulate these patients to prevent thrombosis, but without exposing them to too much bleeding risk. So I think our one real challenge remains eligibility. We've seen from Paolo that is getting a lot better. We've got a little bit more work to do on that.
Perfect points. We have a question from the audience, and please go to the microphone.
Thank you very much. I have a question about the observation for rhythm disturbances. How long do you do that, and what is the pacemaker rate in these systems?
So I can give this to Thomas perhaps, but to make the short point, it is much less than on the tricuspid or on the TAVR space. So we don't have the problem that we actually interrogate so much with the Koch triangle. So there is no rhythm problem actually with TMVR deployments, unlike the TTVR deployments, where you actually go against the aorta and where you have the Koch triangle. I hand this shortly to the two surgical colleagues to my left side, but I think, Michael, you have the biggest overview. I think there is no sign of any elevated AV block or rhythm disturbance with this valve system, so it's very, very safe. There is less indication than for TAVR and for TTVR.
Yeah, well, Thomas and I know when we operate on the mitral valve that we do repair, we avoid 8 o'clock. You know, we go 10 to 6, 8 o'clock is time for a pacemaker. That's the top of that triangle. Aortic valve, the same thing. The top of the membrane septum is where it runs. This is pretty far away from it. That's really not something we worry about with this valve.
Okay.
One final question.
So one final question here. Make it short. We have 30 seconds to go.
No, the criteria you have shown for the Apollos were like 200, but both the cases were much, much lower, neo-LVOT of 90. What is the lowest kind of neo-LVOT you can safely deploy this device?
So we've been talking about this. I mean, you can give him the same answer that we...
Yeah, so there's been a number that are less than 100, but we don't go just on neo-LVOT. We've actually went back over all the cases we did, and we looked at the cases that had a obstruction that led to either death or surgery, an obstruction that led to only medical therapy, or no obstruction, red, yellow, green. And we looked at what criteria and developed a mathematical formula for what put you in the red zone. And we now use that formula to then say, here are the people we're going to approve. We've kind of moved it into the yellow zone to eliminate some of those. We'll probably move it down as time goes on, but again, this is part of a trial. And the biggest factor in that is the septal thickness, because it has to do the square of the septal thickness. So if you're pretty close, we have a good idea if you go back and do an alcohol septal ablation, if you have a good artery, or a sesame, or any other kind of ablation, we will probably get you in. But if you don't get anywhere close, you're probably not going to get in.
So 100.
Well, no, I mean, in other words, the number alone is not determinant.
Yeah.
We have some other factors that we look at.
Yeah.
And this is the new score and the modified way we look at it.
It's not like the old days where we took the 40% neo-LVOT and said, if it's below this, we're not going to do it. That's just one of the factors that go into it. That average wall thickness in the septum, the square of the septum.
Yeah, and the angle between the aorta and the mitral also is one of them. Thank you.
So I would like us to close the session with Thomas, and I think the first one is a handshake. I think this innovation was driven with the interaction in the cardiovascular professional field with heart surgeons and cardiologists going into the same direction with industry and here with Medtronic, keeping the track over 1 decade of development. But we came to a goal. We came to a tunnel that is showing a very bright light, and this is, we're approaching 700 implants worldwide. We are crossing 100 with the latest transfemoral system, and the device was successfully delivered from a transapical approach in the early days that Michael Redden knows a lot of, to a very, very safe situation where now our mortality numbers at 30 days are dropping significantly. And in a perspective, as we know that the group is expanding, like in TAVR, we're moving to lower and lower 1-year mortalities. And I think we have a very bright future with more and more experience. We'll learn more about LVOT obstruction. We'll learn more about modification of the septum, and both by medication and by devices, and of the anterior leaflet. And we will get a higher screen pass rate in the very near future. So we're looking forward that this becomes the third TMVR product and the first single-step product actually in a transeptal approach. And with this, I would like to close the session in time, not to get in conflict with PCR. And we were happy about a packed room, and I think we see a bright 2026 for this further iteration in the toolbox of structural heart disease. Thank you very much.